Good day, everyone. Let us prepare ourselves as we will study and learn the Bible of psychologists, which is the DSM. I am Jala Abrique, and at the end of our discussion, we will be able to identify and explain neurodevelopmental disorders, particularly the intellectual developmental disorders, the communication disorders, autism spectrum disorder, and attention deficit hyperactivity disorder. But before we will dig deeper in the disorders, let us have first a brief discussion about the DSM. So in my PPT po, words highlighted with green color are additional information sa DSM-5-TR na wala sa DSM-5, while words naman highlighted with blue color are words in DSM-5 or informations in DSM-5 na inelaborate at ni-revise po sa DSM-5 TR. So the Diagnostic and Statistical Manual of Mental Disorders, or the DSM of the American Psychiatric Association, is a classification of mental disorders with associated criteria designed to facilitate more reliable diagnosis of these disorders. DSM is a medical classification of disorders and as such serves as a historically determined cognitive schema imposed on clinical and scientific information to increase its comprehensibility and utility. So the DSM has successive editions over the past 60 years. The diagnosis of a mental disorder should have clinical utility. The diagnosis of a mental disorder is not equivalent to a need for therapy, kasi nga po pag sinabi natin na need for treatment na ito po ay komplikado that takes into consideration ang symptom severity, ang symptom salience, kung may suicidal thoughts na ba, yung distress, yung mental pain associated with the symptoms, the disability related to the symptom, risk and benefit of available treatment, and other factors. Meron din namang hindi nila nami-meet yung full criteria ng isang disorder pero nag-demonstrate na kailangan din nila ng treatment or care at hindi sila dapat pagkaitan nun. It should be also noted that the definition ng mental disorder was developed for clinical, public health, and research purposes and even in legal judgments. So ang DSM po ang standard reference ng clinical practice sa mental health field for the past 60 years and counting. And the classification of a disorder is harmonized with the World Health Organization's International Classification of Diseases, or the ICD. Before each disorder name sa DSM-5-TR po, ICD-10 CM codes are provided. Sa DSM-5 naman, mauna yung ICD-9 code and then followed by the ICD-10 code na nakalagay sa parenthesis. Pag blank lines naman po, blank lines, it indicates that the ICD-10 CM code depends on the applicable subtype, specifier, or class of substance. Yung nasa parenthesis naman po sa DSM-5-TR is ang page number. Note, for all mental disorders due to another medical condition, insert the name of the etiological medical condition within the name of the mental disorder due to the medical condition. So, the code and name for the etiological medical condition should be listed first immediately before the mental disorder due to the medical condition. Let us have a brief history of the DSM. So DSM-1, the first edition appeared in 1952. The use of the term reaction throughout the classification reflected the influence of Adolf Meyer's psychobiological view that mental disorders represented reactions of the personality to psychological, social, and biological factors. Ang DSM-2 naman is based on ICD-8, and both the DSM-2 and ICD-8 went into effect in 1968. Yung DSM-3 naman is based on ICD-9. Moreover, the inconsistencies in the system of DSM-3 led to DSM-3 revised in 1987. DSM-4 naman was published in 1994. That was a culmination of a 6-year effort that involved more than 1,000 individuals and numerous professional organizations. ICD-10 was published in 1992. Efforts resulted in increased congruence in the two systems, the DSM-4 and ICD-10. DSM-4-TR was published in July 2000, and the creation of the 5th edition, or the DSM-5, was a massive undertaking that involved hundreds of people working toward a common goal over a 12 period and was published on 2013. Furthermore, the DSM-5 is multi-axial. The DSM-5-TR naman, the development of DSM-5-TR involved more than 200 experts, and the majority of the experts were involved in the development of DSM-5. They were given the task of conducting literature reviews covering the past 10 years and reviewing the text to identify out-of-date material. And it was published, the DSM-5-TR was published this year, 2022. Due to the differences in timing, complete harmonization of the DSM-5 diagnostic criteria with the ICD-11 disorder definitions was not possible because because the DSM-5 developmental effort was several years ahead siya sa ICD-11 revision process. DSM contains sections and they are the following. First, we have the recording procedures. It provides guidelines for reporting the name of the disorder and for selecting and recording the appropriate ICD-10-CM diagnostic code. It also includes instructions for applying any appropriate subtypes or specifiers. Yung subtypes at specifiers provide ng brief description ng applicable subtypes or specifiers. Yung diagnostic features naman, provide siya ng descriptive text illustrating the use of the criteria, and it includes key points on their interpretation. Yung associated features naman, it includes clinical features that are not represented in the criteria but nag-occur siya significantly more often sa mga individual na meron yung disorder than those without the disorder. Yung prevalence naman describes the rate of the disorder in the community. Most often, ito ay 12-month prevalence, and although for some disorders, point of prevalence is noted. Prevalence estimates are also provided sa age group, sa ethno-racial cultural group, and if possible, meron din sa sex ratio. Yung development course naman, nag-describe ng typical lifetime patterns of presentation and evolution of the disorder. Yung risk and prognosis factors, nag-include ng discussion ng factors na nag-contribute sa development ng disorder. Next online, we have the culture-related diagnostic issues. Ito yung nag-a-address sa culture sa isang disorder. Next, you have the sex and gender-related diagnostic issues. It includes correlation ng diagnosis that are related to sex and gender. Yung diagnostic markers naman addresses objective measures that have established diagnostic value. At yung association with suicidal thoughts or behavior, nag-provide ng information about the disorder-specific prevalence of suicidal thoughts or behavior, as well as also the risk factors for suicide that may be associated with the disorder. Yung functional consequences naman, nag-discuss ng notable functional consequences associated with a disorder that are likely to have an impact sa isang individual. Next, we have the differential diagnosis. Ito, nag-discuss how to differentiate the disorder from other disorders na merong similar presenting characteristics. At lastly, we have the comorbidity. It includes the descriptions of mental disorders and other medical conditions likely na nag-co-occur with the diagnosis. And now we are on the neurodevelopmental disorders. So neuro means that these disorders are neurologically based and developmental because these disorders show themselves early in life and often nag-persist sila as the person grows older. Kasi nga neurodevelopmental, it means that it is characterized by developmental deficits or differences sa brain processes na nagpapahina sa personal, social, academic at occupational functioning. The diagnosis of these disorders requires the presence of both ng symptoms and impaired functioning. Neurodevelopmental disorders co-occur with one another with mental and behavioral disorders. So disorders that appear early in life disrupt the normal course of development. In neurodevelopmental disorders, interrupting or preventing the development of one skill impedes mastery of the skill that is normally acquired next. And knowing what skills are disrupted by a particular disorder is essential para malaman natin kung anong i-develop natin na appropriate intervention strategies. So, neurodevelopmental disorders includes intellectual developmental disorders, communication disorders, autism spectrum disorder, attention deficit hyperactivity disorder, specific learning disorder, motor disorders, and other neurodevelopmental disorders. And particularly, I will be discussing about the intellectual developmental disorders, which includes the intellectual developmental disorder, or intellectual disability, the F88, global developmental delay, F79, and specified intellectual developmental disorder. And under naman sa communication disorders, you have the F80.2 or the language disorder, the F80.0 or the speech sound disorder, F80.81, the childhood onset fluency disorder, F80.82, the social pragmatic communication disorder, and F80.9, the unspecified communication disorder. And under naman sa autism spectrum disorder, we have the F84.0 or the autism spectrum disorder. And lastly, I will be discussing about the attention deficit hyperactivity disorder that includes attention deficit hyperactivity disorder, the F90.8 or the other specified attention deficit hyperactivity disorder, and the F90.9 or the unspecified attention deficit hyperactivity disorder. First, online, we have the intellectual developmental disorders, and under it, we have the intellectual developmental disorder or the intellectual disability. So, in the DSM-5, it was called intellectual disabilities. At yung nasa labas ng parenthesis, at yung sa loob naman ng parenthesis pala is the intellectual developmental disorder. So, they nag-change sila. The onset is during the developmental period that includes both intellectual and adaptive functioning deficits in conceptual or the academic, social, and practical domains. So the following three criteria must be met. First, we have the deficits in intellectual functions such as reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience confirmed by both ng clinical assessment and individualized standardized na mga intelligence testing. So for criterion A, it involves deficits in general mental abilities. So critical components includes verbal comprehension, working memory, perceptual reasoning, quantitative reasoning, abstract thought, and cognitive efficacy. So intellectual functioning is typically measured with individually administered and psychometrically valid, comprehensive, and culturally appropriate tests of intelligence. For the criterion B, we have the deficits in adaptive functioning that nagresulta siya ng failure to meet developmental and sociocultural standards for personal independence and social responsibility. And without ongoing support, the adaptive deficits limit functioning in one or more activities ng daily life such as communication, social participation, and independent living across multiple environments such as sa home, sa school, sa work, and sa community. So, impairment in criterion B, impairment in everyday adaptive functioning of individuals' age, gender, and socioculturally matched peers. Deficits in adaptive functioning refers to how well a person meets community standards of personal independence and social responsibility. So, in comparison to others of similar age and sociocultural background, adaptive functioning involves adaptive reasoning in three domains. First, we have the conceptual or the academic domain. It involves competency in memory, language, reading, writing, math, reasoning, acquisition of practical knowledge, problem solving, and judgment in novel situations, among others. Sa social domain naman, nag-involve ito ng awareness of others' thoughts, feelings, and experiences, ng empathy, ng interpersonal communication skills, ng friendship abilities, and social judgment, among others. Sa practical domain naman, it involves learning and self-management across life settings, including personal care, job responsibilities, money management, recreation, self-management of behavior, and school and work task organization, among others. So, intellectual capacity, education, motivation, socialization, personality features, vocational opportunity, cultural experience, and coexisting other medical conditions or mental disorders influence adaptive functioning. So, criterion B is met when at least one of those three domains of adaptive functioning is sufficiently impaired that ongoing support is needed na in order for the person to perform adequately across multiple environments such as in home, school, work, and community. And lastly, we have the onset of intellectual and adaptive deficits during the developmental period, or the criterion C. So, criterion C it states that onset is during the developmental period that refers to recognition that intellectual and adaptive deficits are present during childhood or adolescence. So, ang severity level ng intellectual developmental disorder or intellectual disability ay pwedeng maging mild, moderate, severe, or profound. It ranges from F70 to F73. At ang levels of severity nito ay defined based on adaptive functioning dahil ang adaptive function ay nag-determine ng level of support na kailangan ng isang bata. First, we have the mild or the F70. So, sa conceptual domain, sa preschool, no obvious. Hindi pa obvious. Sa school age and adults naman, difficulties in learning academic skills. Sa adults, impaired abstract thinking, executive function, short-term memory, and functional use of academic skills. Sa social domain naman, mild ito kapag merong immaturity in social interactions, merong communication, conversation, and language are more concrete or immature than expected for age. Merong difficulties regulating emotion and behavior, at merong limited understanding of risk in social situations. Sa practical domain naman, some support with complex daily tasks, healthcare decisions, and legal decisions, and to learn to perform a skilled vocation competently and even in raising a family. Next, you have the moderate or the F71. Sa conceptual domain, conceptual skills lag markedly sa preschoolers. Language and pre-academic skills develop slowly. Sa school age naman, progress in reading, writing, mathematics, and understanding of time and money occurs slowly. At sa adults, support is required na. In social domain, moderate ito kapag mayroong capacity for relationship na evident. Next, we have the social judgment and decision-making abilities are limited. Next, significant social and communicative support is needed in work settings for success. And lastly, sa practical domain, moderate siya if the individual can care for personal needs, although nangailangan ng teaching. Time and reminding is also needed for the individual to become independent in this area. And independent employment in jobs that require limited conceptual and communication skills can be achieved, but considerable support is needed. Next, severe or the F72. So sa conceptual domain, attainment of conceptual skills is limited. Tapos, little understanding of written language or of concepts involving numbers, quantity, time, and money. At caretakers provide extensive supports for problem solving throughout life. Next, sa social domain naman, severe siya if spoken language is quite limited. Language is used for social communication more than for explication. At yung individuals understand simple speech and gestural communication. Sa relationships naman with family members and familiar others are source siya ng pleasure and help. Lastly, we have the practical domain. Severe siya if it requires support and supervision for all activities of daily living at all times. The individual also cannot make responsible decisions. In adulthood, participation in tasks at home, recreation, and work requires ongoing support and assistance. Sa skill acquisition in all domains involves long-term teaching and ongoing support. And maladaptive behavior including self-injury is present in a significant minority. And lastly, profound F73. For the conceptual domain, the individual may use objects in goal-directed fashion for self-care, work, and recreation. Certain visuospatial skills such as matching and sorting based on physical characteristics may be acquired. However, co-occurring motor and sensory impairments may prevent functional use of objects. Sa social domain naman, Ang individual has the individual has very limited understanding of symbolic communication in speech or gesture, and the individual enjoys relationship and respond to social interactions through gestural and emotional cues. Co-occurring sensory and physical impairments naman may prevent many social activities. Lastly, sa practical domain, the individual is dependent on others for all aspects of daily physical care, health, and safety. Although he or she may be able to participate naman in some of these activities as well. Individuals without severe physical impairments may assist with some daily work tasks at home. And recreation activities, nag-need siya ng support mula sa iba. Maladaptive behavior naman is present in a significant minority. For its associated features naman, intellectual developmental disorder is a heterogeneous condition with multiple causes. So it involves associated difficulties with social judgment in assessment of risk that leads to increased accidental injury rates and exploitation by others. Also, self-management of behavior, emotions, or interpersonal relationships. Also, motivation in school or work environments, and individuals become distressed about their intellectual limitations but cannot be seen as having an impact in functioning. For its prevalence naman, in DSM-5, general population prevalence is approximately 1% and prevalence rates vary by age. So, prevalence for severe intellectual disability is approximately 6 per 1,000. Dito naman sa DSM-5-TR, overall general population prevalence is approximately 10 per 1,000. And in middle-income countries, approximately 16 per 1,000. Global prevalence is nagabari siya by country and sa level ng development ng isang country. So, intellectual developmental disorder is higher in youth than in adults. In the United States naman, prevalence per 1,000 population does not vary significantly by ethno-racial groups. For the development and course, so age and characteristic features at onset nagadepend sa etiology and severity of brain dysfunction. Sa first 2 years, merong identifiable na delayed motor, language, and social milestones. If associated siya sa genetic syndrome, merong characteristics sa physical appearance such as in Down syndrome. Ang ibang syndromes ay meron ding behavioral phenotype, which refers sa specific behaviors na karakteristik ng isang particular genetic disorder. In acquired forms naman, the onset may be abrupt following an illness. So this disorder is non-progressive, but it is lifelong and severity may change over time. For the risk and prognosis factors naman, so prenatal etiologies, it includes genetic syndromes, inborn errors of metabolism, brain malformations, maternal disease including placental disease, and environmental influences. Prenatal or during naman sa pagbubuntis, causes includes a variety of labor and delivery related events leading to neonatal encephalopathy. Lastly, we have the postnatal or causes include hypoxic ischemic injury, traumatic brain injury, infections, demyelinating disorders, seizure disorders, and chronic social deprivation and toxic metabolic syndromes and intoxications. For the culture-related diagnostic issues, intellectual developmental disorders, occur across ethno-racial groups. So sa DSM-5, imbis na ethno-racial groups, ang nakalagay is all races and culture. So cultural sensitivity and knowledge of socio-structural conditions are needed during assessment. And cultural explanations for intellectual developmental disorder vary and may include cultural beliefs. For the sex and gender-related diagnostic issues naman, so sa DSM-5, ang section ito is also gender-related diagnostic issues. So overall, males are more likely than females to be diagnosed with both mild and severe forms of intellectual disorder. However, yung sex ratios nagavary siya widely in reported studies. Next, we have the association with suicidal thoughts or behavior. So this section is not included in the DSM-5, rather dito sa particular na disorder na to, it is found in the associated features supporting diagnosis. So, yung mga taong may intellectual developmental disorder can be at risk for suicide associated with comorbid mental disorder, higher intellectual and adaptive function, and immediate past stressors. So, yung comorbidity and screening for suicidal thoughts is important in screening process with particular attention to change in behavior of the individual. For the differential diagnosis, so the diagnosis of intellectual developmental disorder should be made whenever criterion A, criterion B, and criterion C are met. If merong genetic syndrome na ginaling sa intellectual developmental disorder, it should be noted as a concurrent diagnosis. So first, we have the major and mild neurocognitive disorder. So it includes loss of cognitive functioning. So if major neurocognitive disorder occurs, both diagnoses of disorders may be given. Also, both neurocognitive disorder and intellectual developmental disorder diagnosis can be used if diagnostic criteria are met for intellectual developmental disorder. Next, we have the communication disorders and specific learning disorder. So these disorders are specific to communication and learning. They also may co-occur if full criteria are met for the two disorders and both diagnoses are made. So for autism spectrum disorder naman, intellectual developmental disorder is common on individuals with autism spectrum disorder. So appropriate assessment of intellectual functioning in autism spectrum disorder is essential with reassessment across the developmental period because IQ scores in autism spectrum disorder may be unstable, particularly in early childhood. Next, for the comorbidity. So neurodevelopmental and other mental and medical conditions are frequent in intellectual developmental disorder with rates of some conditions 3 to 4 times higher than in the general population. So, ang mga common na co-occurring neurodevelopmental and other mental disorders are ADHD, depressive and bipolar disorders, anxiety disorders, autism spectrum disorder, stereotypic movement disorder, impulse control disorders, and major neurocognitive disorders. So, knowledgeable informants are essential for identifying symptoms such as irritability, mood dysregulation, aggression, eating problems, and sleep problems, and for assessing adaptive functioning in various community settings. So, individuals with intellectual developmental disorder disproportionately have more health problems, including obesity, than the general population. So, frequently, yung mga may intellectual developmental disorder, they cannot verbalize physical symptoms na na-experience nila. And ito ay nagalid ng health problems nagalid ito sa kanilang mga health problems being undiagnosed and untreated. So, for the relationship to other classifications, yung ICD-11 uses the term disorders of intellectual development to indicate that these are disorders na nag-involve ng impaired brain functioning in early life. So, these disorders are described in ICD-11 as a meta-syndrome occurring in the developmental period analogous to dementia or major neurocognitive disorder in later life. So, intellectual developmental disorder was previously termed as mental retardation and was changed to intellectual disability. At ngayon sa DSM-5-TR, it is called as intellectual developmental disorder. So, the DSM-5 criteria for intellectual developmental disorder no longer includes numeric cutoffs for IQ scores, which were present in previous versions. So there are literally hundreds of known causes of intellectual disability. So, in addition, other prenatal factors that can produce intellectual developmental disorder includes the pregnant woman's exposure to disease and chemical and poor nutrition. Also, lack of oxygen during birth and malnutrition and head injuries during the developmental period can lead to severe cognitive impairments. So, multiple genetic influences appear to contribute to intellectual developmental disorder that includes chromosomal disorders, single gene disorders, mitochondrial disorders, and multiple genetic mutations. So, a portion of the people with more severe intellectual developmental disorder have an identifiable single gene disorders involving a dominant gene, a recessive gene, or an X-linked gene. So, one study of children from Germany and Switzerland found that a variety of genetic mutations, including de novo disorders or the genetic mutations occurring in the sperm or egg or after fertilization, were present in those children with intellectual developmental disorder of unknown origin. So, one example of a dominant gene disorder is the tuberous sclerosis. It is relatively rare, occurring in one of approximately every 30,000 births, and about 60% of the people with this disorder have intellectual developmental disorder, and most have seizures. For the chromosomal influences naman, Down syndrome is the most common chromosomal form of intellectual developmental disorders. For the psychological and social dimensions naman, cultural influences that may contribute to intellectual developmental disorder can include abuse, neglect, and social deprivation. So sometimes referred to as cultural familial intellectual disability. People with these characteristics are thought to have cognitive impairments that result from a combination of psychosocial and biological influences, although the specific mechanisms that lead to this type of intellectual disability are not yet understood. Fortunately, because of better childcare systems and early identification of potential family difficulties, these cases are rare today. For the treatment of intellectual developmental disorder, for individuals na merong mild intellectual developmental disorder, intervention is similar to that of people na merong learning disorders. So, specific learning deficits are identified and addressed to help the student improve such skills such as reading and writing. At the same time, these individuals often need additional support to live in the community. So, individuals with intellectual developmental disorder can acquire skills through the many behavioral innovations first introduced in the early 1960s, which teaches such basic self-care such as dressing, bathing, feeding, and toileting to people with even the most severe disabilities. So success in teaching these skills is usually measured by the level of independence people can attain by using them. So typically most individuals, regardless of their disability, can be taught to perform some skills. For communication training naman, it is important for people with intellectual developmental disorder. Making their needs and wants known is essential for personal satisfaction and for participation in most social activities. So the goals of communication training differ depending on the existing skills. So people with mild levels of intellectual developmental disorder, the goal may be relatively minor or more extensive. So for individuals naman with most severe disabilities, communication skills training can be particularly challenging because they may have multiple physical or cognitive deficits that make spoken communication difficult or impossible. But however, creative researchers use alternative systems that may be easier for these individuals, including sign language, used primarily by people with hearing disabilities, and augmentative communication strategies. So, augmentative strategies may use picture books, teaching the person to make a request by pointing to a picture. So, for the alternatives to punishment naman, alternatives to punishment that may be equally effective in reducing behavior problems such as aggression and self-injury includes teaching people how to communicate their need or desire for such things as attention that they seem to be getting with their problem behaviors. So, in addition to ensuring that people with intellectual developmental disorder are taught specific skills, caretakers focus on the important task of supporting them in their communities. So supported employment involves helping an individual find and participate satisfactorily in a competitive job. So in summary, there is no biological intervention, but there is a behavioral focus similar to that for autism. So prevention includes genetic counseling, biological screening, and maternal care. So under intellectual developmental disorders, we also have the global developmental delay. So this diagnosis is reserved para sa mga individuals under the age of 5 years when the clinical severity level cannot be reliably assessed during early childhood. So this category is diagnosed when an individual fails to meet expected developmental milestones in several areas of intellectual functioning and applies to individuals who are unable to undergo systematic assessments of intellectual functioning, including children who are too young to participate in standardized testing. So this category requires reassessment after a period of time. And lastly, under intellectual developmental disorders, we have the unspecified intellectual developmental disorder. So this category is reserved para sa mga individuals naman over the age of 5 years, when assessment of the degree of intellectual developmental disorder by means of locally available procedures is rendered difficult or impossible because of associated sensory or physical impairments, katulad ng blindness or bilingual deafness, tsaka locomotor disability or presence of severe problem behaviors or co-occurring mental disorder. So this category should only be used in exceptional circumstances and requires reassessment after a period of time.